Okay, on my third screen, I can see the chat this time. So even when our videos are up and stuff, I think I can, I think I can still see it. It's going to take some finagling because, you know, when I went to nursing school, it was 22 years ago. And my last semester, they said, you have to sign up for this thing called an email. And you have to communicate with your instructor at least 2 times during the semester. And I thought, this is ridiculous. Who the heck's going to need an email when all I want to be is a nurse? I don't need all of this crazy fandangled stuff just to be a nurse. And now look where we are. So we'll see how my technology works. Okay, well, just a quick announcement about Canvas announcements. I want you guys to make sure that you are reading them regularly or that you turn on your notifications so that when you get them, I try to give you updates or reminders or things like that, and I use Canvas announcements a lot. Other than that, I don't think we have any other announcements, so I'll tell you a joke before we start with our student presentations. So there were these burglars, and they broke into this house, and it was really dark, and as they tiptoed in, they hear this, Jesus is watching you. And they stop for a minute, and they look around, and they think, okay, I don't see anything. And so they start to come in a little further, and they hear, Jesus is watching you. And they look over into the living room, and they see this bird cage. And they go over there, and they uncover it, and they said, can you talk? And he said, yeah. And he said, are you the bird that's been saying, or he said, what's your name? And he said, Clarence. And he said, are you the one that says Jesus is watching you? And he said, yep. And he said, what kind of idiot would name a bird Clarence? And he said, the same idiot that named the Rottweiler Jesus. Oh, snap, huh? Okay. So feel free to type your laughter in the chat. All right, so our first, oh good, thanks you guys. You do my heart good. All right, so our first presentation is postictal phase nursing care, actually patient teaching on seizure disorders. Sorry, I didn't mean to scare you. Maya, you are second, so let me fix this. And we'll see here. Okay, can you guys see a very large version of postictal phase of a seizure and nursing interventions? Please say yes. Either on your mic or on the chat. Beautiful. Okay, so far so good. All righty, so Miss Megan, would you like to enable your mic? And I will be your slide advancer, I guess.
Yeah.
To make sure that we get through your slides.
Sounds good. All right, so yeah, I guess you can go to the next slide since we've.
Okay.
Okay, so just right now, if you can, just get out like a piece of paper, a blank paper. It doesn't matter if it's notebook or printer, just get out a blank piece of paper.
Okay.
Okay, so this is just a little bit of a review from yesterday, but just the different phases of a seizure. So there's the prodromal stage, and with this, you can either notice like they can have like early signs. It can be hours or days prior to a seizure. And then there's the aura stage, and then the ictal or middle stage, and then the post-ictal or ending stage, which is like the recovery stage, which I will be talking about. So with the post-ictal phase, it differs from person to person or from seizure to seizure. So it may be more than a few minutes, or it could last for a few days. It just depends on the seizure type, the severity, and the region of the brain affected. Some people, they may remember having a seizure or just remember parts of it or not remember it at all. Often people will want to rest and sleep during this time. That's why it's called like the recovery stage. So some signs and symptoms of the postictal stage, and we kind of went over this yesterday. So it's like confusion. They can have lack of consciousness, just fatigue or exhaustion. They could have a headache, loss of bladder or bowel control, fear and anxiety, frustration, shame or embarrassment. They could have thirst, nausea, sore muscles, weakness in parts of body, and also they might have injuries because of the seizure. Okay, so my activity is going to be to go ahead and draw what these nursing interventions are so that you can maybe better remember what you can do in a postictal phase. Okay. Okay, so now down to the nursing care. So what you want to do is for sure notify the physician of like what just happened, that they just had a seizure. You want to stay with the patient for safety reasons. And then also keep or turn the patient on their side. And this is just to prevent like aspiration if they throw up or anything like that. And to just facilitate like any drainage or oral secretions. And sometimes it's needed to suction the secretions. And then you'll want to make sure that you check vital signs, including the O2 set. So obviously, if the pulse or respirations are not present, you're going to want to call for help and begin CPR. So after you're checking vital signs and stuff, you want to perform a neurological assessment, see if there's any deficits there, and then assess for any injuries because they can maybe like bite their tongue or if they hit their head, whenever. I mean, just assess for any injuries that they may have. So then continuing on, so you'll want to reorient the patient because they can be confused afterwards. They don't know what just happened sometimes. So just a side note though, that some patients, they aren't ready to talk like too much about the seizure. So just like telling them simply and matter-of-factly like what just happened can be helpful. And then provide comfort measures. So like a blanket for warmth, whatever that may be, their favorite toy, whatever that may be. Provide emotional support and help calm the patient. So just reassure them that they're reassure them that they're okay, it's all right, and that they may be embarrassed. So just reassure them like to not be embarrassed and to not be afraid. Okay. So some other nursing cares is you'll want to provide privacy for them. Like I said earlier, and what Chantel said yesterday, that losing their bladder control or bowel control can happen, and so that can be quite embarrassing. So just provide privacy, and obviously just having a seizure, that's probably not something they don't, that they don't love. So providing that privacy, and then instituting seizure precautions per hospital's policy. So that's just like what we said yesterday, like the bed rails up and padded, doing frequent checks, maybe moving the patient closer to the nurse's station to observe them closely. And then obviously you're going to want to document what just happened. So document like the onset, the type of muscle movements, the progression and duration. If they had bladder or bowel incontinence, you can document like if they had an aura or if they observed any other signs or symptoms before the seizure. And then educate the patient. With educating, it's important to check the importance of monitoring their EAD levels and maintain their therapeutic medication levels. Maybe educating them on possible drug interactions if that was a cause. And then just encourage the client, if they do have seizures, maybe just encourage them to wear like a medical bracelet or necklace at all times. And then that's it.
Perfect. Good job. You touched on a lot of things. I think that that's really great. There are a lot of pieces to taking care of them in their postictal phase. And when she said they're really lethargic and sleepy, sometimes that can last minutes up to a much longer period of time, make sure they remain NPO until they're alert and awake enough to protect their airway well. They can sit up, usually more or less unassisted. If they're still a little wobbly, but they're talking and they're okay and they want a little drink, that's okay. But if family members are trying to say, here, wake up, take a drink, sometimes they'll do that. So just make sure that they know also to remain NPO until they're alert. And then time it the same as you would time your seizure, time your postictal phase. Okay, let's see. Now we're going to try to switch presentations without making a mess. Okay. Do you guys see patient and family teaching on seizure disorders?
Yes.
Beautiful. Okay, Miss Maya, is that you that's on?
Yep.
Okay. All right, take it away, my friend.
All right, so mine is on patient and family teaching on seizure disorders. Next slide. So some types and causes. Some seizures can cause arms, legs, and the rest of body to spasm, as we were talking about yesterday. The others can make the person being affected stare off into space or have the inability to respond when you're interacting with them. It's just important to make the family aware of this so that they are prepared in case it does happen. They vary on length from a few seconds up to several minutes. Some causes could be infections, head injury, alcohol or drug abuse, stress, photosensitivity, but most commonly epilepsy, and oftentimes the cause is unknown as well. Focal seizures start in one certain area, but can turn into generalized seizures, which affect both sides. And you can see on the chart on the left, or the right, sorry, that most seizures are related to epilepsy, but there's a good chunk that also isn't related. Next slide. So some signs and symptoms that the family should be aware of, that it differs for everyone. Being able to recognize the onset of seizures can help prevent injury and getting them immediate care if they end up hitting their head or, like Megan was saying, biting their tongue. And so oftentimes they experience confusion and aura, which we were talking about yesterday. They can fall, stare off into space, uncontrolled jerking movements, a strange sensation or emotions, days or even hours or minutes before it happens, and a loss of consciousness or awareness as well. Next slide. How other people can help people who are having seizures, and the family should be really comfortable with doing this, or whoever's helping the person being affected. There really isn't much that you can do when this is happening until they're coming out of the seizure, but you just want to cushion their head, loosen any tight clothing because they're convulsing and you just don't want them to have restricted airways. Turn on their side so they don't aspirate, time the seizure if you have an opportunity, but if you've ever experienced a seizure, it's kind of hard to think about all these steps all at once. Don't put anything in the mouth. Look for an ID on their wrist or ankle, or sometimes they have a little thing in their wallet as well. As the seizure ends, offer for help or have somebody call 911 if it's needed. Megan kind of went over this, but it's also important to recognize the phases so the family isn't taken off guard. The beginning phase, people can sense it about a couple hours to days before it happens. This is the stage where they experience mood changes, anxiety, lightheadedness, can experience loss of focus or difficulty sleeping. It's all dependent really on the person. Not everybody experiences that, but in aura, they experience deja vu sometimes, odd smells, sounds or taste can be off, nausea, headache, intense fear or panic. The middle stage is the ictal phase. This starts with the first symptom of a seizure and ends with the end of the seizure. So convulsions, loss of consciousness, memory lapse. And then the ending or post-ictal phase is the recovery stage. They may still be confused, tired, loss of bladder or bowel control, and be embarrassed because of that. So just try and make them feel like they aren't alone or to be blamed for that because they're not conscious or aware of what's happening. Next slide. What the person being affected can do. They can try and help prevent their seizures. This isn't always possible, but medications do really help. It's just important to be consistent with taking the medications and never go cold turkey. Get enough sleep, avoid alcohol or drugs that may interfere with seizure medications as much as possible. You can teach them relaxation techniques and also how to recognize their aura and plan out days if it's present, like laying down, alerting a family or friend, or calling their healthcare provider just in case anything happens. Leave doors unlocked in case you do have a seizure and you alert somebody that you're having one, and if your doors are locked, they can't get in and help you. So it's always important to do that. Showers, not baths, because if they have a seizure when they're having a bath, they have a possibility to drown. And then just always wear your bracelet for other people's case. Next slide. And then activities, a lot of people, like people with epilepsy or other seizure disorders, aren't able to do a lot of activities. It's encouraged that they do still live a normal life. And so for your patient, if they do have that, encourage them to live as normal as possible. But there are some restrictions, like they're able to do, but they have to have supervision from other people. So just trying to avoid hazardous activities like mountain biking or scuba diving. Always have somebody present when they're swimming. Usually they aren't allowed to drive, but in some cases, it's not all the same for every person with a seizure disorder. So just have them contact their healthcare provider. Cooking, ironing, and using hair tools usually requires supervision, which is kind of hard for them. And so just be aware of that. Educate others, like their boss, coworkers, their teachers, so that they're aware and able to help if necessary. Next slide. Some helpful equipment that you can educate your patient on are obviously the seizure bracelets as an identifier so that other people know in case they're having a seizure in public. There's mattress devices where it's like a little pad that you can put under their mattress, and if there are abnormal movements like convulsions, it'll alert, let's say, the parents, which is really helpful to kind of ease their mind. There's also anti-suffocation pillows that you can kind of see at the right-hand side of the screen in case they're having a seizure. This just helps them the ability for airflow, and so that they never have restriction of oxygen. And then they also have smartwatches. I've had several patients have this where if they're seizing, it will alert the family, and it will also alert the nurse who's on for the night. You can also get service dogs. They're able to sense your aura. And then there's helmets for younger children. And then it's always just good to educate them on that there is support, have them talk to a social worker, get therapy if they need it, and then offer different support groups for them. So for my learning activity, it's just a discussion question in the chat box. What are some signs and symptoms of a seizure, and what steps would you take to help someone that is having one?
Sorry, I was writing that down. One sec. Okay, and there's your sources. Perfect. So if you guys will chime in on the discussion and put your responses in there, I love to read and see what you guys have when you post in those discussion questions. Thank you so much, Miss Maya. You did a very good job. One of the things that I taught some of the patients and families was no bunk beds. If they do have a bunk bed, they need to be on the bottom. That way they don't risk falling. And like the anti-suffocation pillows, soft animals are kind of a risk too. And so making sure that they don't have a lot of stuffed animals and things in their bed that they can kind of end up getting their face into and not being able to breathe very well. Well, good job. All right, ladies, you are done. How nice is that? Okay, let's see. Let's go back to mine. And when I don't have student presentations, I have a couple of these slides that just give you some other ideas, but these guys pretty much touched on everything. The only thing that I want to make sure that we touch on here is when you call EMS, make sure if they have any apnea with signs and symptoms of hypoxia. Let me put this back in slideshow mode. Okay. There we go. Sorry, let me get back. There we go. Any evidence of injury, status epilepticus, any emesis, they don't often vomit with seizures. It's actually more rare than that. And so if they are vomiting, then maybe it was a toxic ingestion that caused the seizure that we had previously been unaware of. And if they're a diabetic and they have a seizure, it can often mean hypo or hyperglycemia that needs treatment beyond probably what we can do right there in the home. Talked mostly about this, things to do. Blow by oxygen if possible. So if you can turn up, it's very hard to get a nasal cannula on them if they're moving all over the place and they do need some oxygen. So getting a blow by, just getting a bag and mask or getting a funnel, like at primaries have a big funnel that's hooked to a tube, and just flood it, turn it up to 15 and just hold it by their face. That will really help them if they're just barely grunting and not breathing very well. We talked about not putting anything in their mouth and NPO until they're alert and oriented, and don't restrain them. Okay, so this is in red again, so this won't be on our test, but I want you to be aware because you'll have patients come in for other things that do have or are using or need some education on some of these other non-pharmacological management pieces. So a vagal nerve stimulator, or a VNS, is surgically implanted. It's usually just kind of like a pacemaker is, just right, I don't know if you can see me, but right under the skin, kind of where a pacemaker is on either side. And it just hooks into the muscle. They just sew it into the muscle. It delivers electrical impulses along the vagus nerve, And it comes with an extra magnet. And so if they're having a seizure, you can take this extra magnet and swipe it right across. I can't see right across. There you go. Right across their magnet, and it can deliver extra impulses and be able to help stop a seizure. But it delivers electrical impulses every couple of minutes for just a few seconds. And whatever that stimulation of that vagus nerve causes helps decrease or even get rid of seizures. And sometimes they don't have to be on any other medications. It can cause some difficulty swallowing and shortness of breath during stimulation. So as soon as it starts delivering that impulse, sometimes it's a little hard for them to swallow, but they get really used to it really fast, and they just stop what they're doing and wait a couple seconds for the impulse to pass. And then it's usually about 30 seconds every 5 to 10 minutes that impulse comes. Research shows that it's a 90% decrease in seizures in about 50% of kids. So really big numbers. And then fewer medications are needed and minimal side effects. Another non-pharmacological piece is 2-stage brain mapping. I'll show you kind of what it looks like, and then we'll go back to that slide. So here's where they take and they open the scalp, and they lay the electrodes right on the scalp. And then it shows the picture on the other side, and it maps hotspots or extra electrical activity in the brain. So it's 2-stage. It does a surgical opening, and then they place the electrodes on the surface of the brain. Then they close the scalp. So they don't necessarily replace the bone at that time. So it's important that this patient doesn't get out of bed, because they have a window, is what that's called, and they don't have any skull that's protecting that, but they close the scalp. The electrodes record the seizures and map it, that piece of the brain. They're awake and conscious while they're being monitored. And then they go to surgery in step 2, and they have the abnormal brain tissue that's been identified in mapping removed. Another one is a corpus callosotomy, and that's where they sever the connection between both hemispheres. So if you have seizure activity that's starting on one side and it's continuing over to the other side of the brain, then they can sever about 2/3 in a partial callosotomy, or they can sever the entire thing. Usually for generalized tonic-clonic and drop attack seizures, those are usually when these are quite effective. Partial is the front 2/3, and then it can't spread. A partial decreases 70 to 80% of seizures, and a complete is about 90% effective. And the interesting thing, if you sever that connection, and the two hemispheres don't talk to each other, you can put like an orange in one hand, and as with like their eyes closed, and as they feel it, they can describe it. And then you put it in the other hand, they can give you the name, but it's very difficult to describe. So kind of cool. All right, and then cannabis. Cannabidiol or CBD, hemp oil, is not THC. And a lot of people have said they want to try this for their child, or their child has had no success with ketogenic diets, lots of medications, and they really want to go this route. It's not like typical medical marijuana that uses the whole plant, but it has no standards for dosing. So sometimes they can get some CBD oil that has a lot of cannabidiol in it, and it controls their seizures. And then they run out of that, and they go back and they get other CBD oil, excuse me, and they don't have as good a control. And so it's usually that the concentrations are different. It's made with different substances containing the cannabis. Cognitive slowing, but not as psychoactive as higher THC concentrations, so it doesn't produce a high. But they do get kind of slow and sleepy, a little bit slurred with their speech. And then some seizure meds can interact with CBD, so make sure that they know that when you're doing your patient education. And long-term consequences haven't really been studied. in depth. And so I know that some research studies they're trying to do that because this is legal in more states to be able to use this, most everywhere, to be able to use it for seizures. And so they're doing some more research, but right now they don't know a lot about long-term consequences. And the last one is herbs. So make sure that they know to consult a reputable herbalist, someone who is trained or studied or whatever, that really knows what they're talking about. With the herbs, there's not a lot of valid information, and some herbs trigger seizures, and some interact with seizure medications. So make sure that your patients know that. And then tests are being done on an ingredient like cannabis. In some of these herbs, I couldn't find out what that ingredient was, but I know that there's a lot of herbal research that's being done. And for Chinese herbs, there are some tests being done on an ingredient in a Chinese moss plant. I'm not really sure how that's going to take off or what that is incorporated into, but I did see a research study where they were looking at that. And then just others, the potency is influenced by the plant or the plant parts to make the herb. And so that's how it can be very variable. Oh, let's see. I forgot to watch the chat. Let's see here. Oh, place them on a soft surface. Oh, are they severing a nerve? Stephanie, with the corpus callosotomy, I'm thinking is what you're talking about. And they sever the connection, the entire corpus callosum that goes between the two hemispheres. And they sever that connection so that you have two brain hemispheres with no connection. And then all this information in red is just for our information, yes, and won't be on the test. Is that correct? Yes. So anything in red, and then on here, the purple that's telling you these things, I want you to just be aware of, because there are things that will come up in just indefinitely when you're talking with families about seizures. And so I want you to have just that little bit of education in your pocket. So all of these last few sides that are in red will not be tested on. All right. I wouldn't touch it with a 10-foot pole. Thanks, China. Yeah, I agree, Brooke. All righty. So then we're going to go on to bacterial meningitis. Any other questions, burning questions about seizures? Okay. So bacterial meningitis is inflammation of the meninges and of the brain and spinal cord. Bacterial is more virulent, and so they will get sicker quicker and sicker overall if it's bacterial meningitis as opposed to viral meningitis. Less than a year old is higher risk for bacterial meningitis. Does anybody have any guesses why? Immunities, yeah, you're getting there. So what? Everything's still forming. Run with immunities. Bacterial is treatable. Viral will run its course as the virus, runs 7 to 10 days as the virus runs its course. But Kim's kind of on the right track with immunity. Think about some things that cause immunity. It's immature. That can be part of it. No exposure. Still building antibodies. You guys are dancing all around it. Immunizations. So they at 2 months, 4 months, 6 months, and a year, they get Hib, the Haemophilus influenza type B, and Hib meningitis is huge. That was a huge risk. Lots of kids got it until the Hib vaccine. Then there's pneumococcal meningitis, and that is with the pneumonia shot that the kids get at 2, 4, 6 in a year, and that will help them be immune to that one too. So when they're just 2 or 4 months old, they haven't had all those vaccines to make them immune, and so if they get an exposure, they may fight it a little faster and maybe not have severe problems afterwards that other kids may have, but they don't but they're still at risk for getting it. Okay. Alrighty, and then up to 20% of people with bacterial meningitis will die. 50% have permanent sequelae. So if you take the E away, it's sequela, and that is a lasting problem, something that is secondary to the illness that lasts for a longer period of time or indefinitely. It can just last for a few weeks or months, or it can be longer than that. If you add the E on the end, it makes it plural, sequelae, and so they can have multiple problems that last. It can lead to brain damage, nerve damage, seizures. They can become deaf. They can have a stroke. So rapid diagnosis and treatment is really vital. So here's your basic patho, just kind of a reminder from pathophysiology that the white blood cells accumulate and cover the brain, causing blockage and edema. It may be secondary to other infections or surgeries, often an upper respiratory or middle ear infection. So if they get an upper respiratory infection and then all of a sudden they start running really high fevers and having some confusion, photophobia, and a stiff neck, then those are signs that they may have meningitis. Oh, wow, Olivia. And he had a stroke after he had bacterial meningitis. Yeah, that's rough. Does he have any permanent problems from that, or does he do okay? He has some learning disabilities. Oh, that's too bad. That makes it hard. The bacterial one that college-age people get, yes. So there is a bacterial one that college-age people get. It's called meningococcal meningitis, and we'll talk about that one here in just a minute too. So we'll kind of break it down a little bit. That's another vaccine that they can get, and it started out with just vaccinating college kids, and it moved to high school, and now it's junior high. It's an entrance immunization into junior high. Okay, just like 2 or 3 little statistics for you, because I want you to be able to have not really ammunition, but something to talk about for parents that are a little bit hesitant to get immunizations. Haemophilus influenza type B, or Hib, was the #1 cause of kids under 5 to get bacterial meningitis before the vaccine. And now it's nearly eradicated in the US. But 1 in 8 kids was left with deafness, brain damage, and epilepsy. Meningococcal meningitis, about 15% of kids who get that will die, or people, older people too, not just kids. 1 in 5 will have permanent sequelae like brain damage, deafness, kidney damage, limb amputations, because it does affect the vasculature also, meningococcal does. 11 to 24 years old is when they should get the vaccine. And the last statistic, group B strep, or GBS. So this is important in your moms, making sure before they deliver that we know that GBS status. The bacteria is in the bowels and vagina. About 20 to 30% of women carry this. Most newborns don't get it, but about 10% will die. And many have deafness, brain damage, problems with movement and coordination. So it really is pretty important that we know that GBS status. All right, so your clinical manifestations or your signs and symptoms, they rapidly get very ill. So maybe they've had an upper respiratory infection or ear infection, and now all of a sudden it's ramped up. It's like, wow, we have a high fever. They can't tolerate light, so that's that photosensitivity or photophobia. They have a bulging fontanelle if they're little ones and they still have that anterior fontanelle open. Then you feel it, it's not soft and flat. Sometimes it's bulging. Irritable, lethargic. They'll have kind of this high-pitched cry. They call it a neuro cry, and it's a little bit like a screechy cat, like a cat fight cry. And so it's very different. And that is pretty indicative of some swelling in the brain that's causing some adjustments and changes and pain. They'll have a high fever. Nuchal rigidity is a stiff neck. So you know that that's many of you probably know that that's a hallmark sign. If they have lots of other symptomology, like they have a cold or something, and they're like, I don't know if this is just a high fever, and they're very lethargic because of an upper respiratory infection, but then they start to get a really stiff neck that's very painful. They definitely need to be worked up for meningitis. Photophobia, confusion, excuse me, an altered level of consciousness. So they sometimes they will have very altered level of consciousness. So they'll be very confused, have slurred speech. They'll only be oriented to person. Sometimes not even that. Sometimes they're very, very confused. Rarely or occasionally, emesis and seizures. So in your book, page 721, it says projectile vomiting may be present. Emesis can be present, usually because of the increased intracranial pressure, but it's not usually projectile. So I just wanted to bring that to your attention. But the part that follows that is something that I want you to kind of mix. It says generalized seizures are common in children. And it's not just they can have a seizure with bacterial meningitis, but it isn't common in the sense that everyone has a seizure when they have bacterial meningitis. Oh, Megan. Oh, wow. So her great-grandma died of meningococcal meningitis when she was in her early 30s. Yeah, that's probably before they really identified it well and definitely didn't have a vaccine. That's a newer vaccine. All right, so I have a little video for this meningococcal meningitis. We're going to see if I can share it. Let me see what screen it needs to be on. Can you guys see a student's meningitis story? Can you see that on your screen? Oh, beautiful. I love it. Okay.
I know nothing about meningitis. So the one with the red spots on the arm, stiff neck,
clammy and faint,
achy, a lot of symptoms are sort of being come over. I know you can't look at light, is that right?
I think students as a whole don't have an awful lot of awareness of meningitis.
I think most students are like, they care about something when it's in their face.
Maybe if it was more close to home, we might think about it. I knew meningitis was a very serious disease. I wasn't actually aware that it was so serious among students. You just never think it happened to any of your friends, or you'd ever be in that situation when you have to test somebody for it. One morning, I woke up, went to lectures as usual, felt absolutely fine, and started to feel a bit ill.
We were going over lecture, and I was asking if he was going to play football, and he said no. Feeling very groggy, and he was going to come and fancy the door.
I can remember my body just feeling very, very cold, and wanted to really get back to Hall's Rest and get up against the radiator and have a hot shower. I remember having this awful headache, which got worse and worse, and it ended up, it really was absolutely splitting my head, really. It was really very painful. It did feel like being drunk in a way, you know, it got steadily worse and worse. It was hard to sort of do basic tasks. I don't think I left my room at all on the Wednesday. When I first realised something was wrong with Tom, like really wrong with Tom, was when I went to see him on the Wednesday night. I'd been to see the boys and they told me that he was ill. I can remember Robert distinctly saying, "Oh, Tom's in his room, he's got flu at work."
She decided to check on him. He came out, knocking his door.
So I was banging on his door and I could hear him in his room and he was just shuffling about and I just thought he was ignoring me. She kept banging on the door until I got it because I wasn't talking properly through the door. And it was when he opened his door, really, that I realised something was really wrong.
Didn't know his name, couldn't tell us what date it was. He just seemed drunk.
It really did look terrible. It was like a really grey, creamy colour.
I've never seen anyone skin colour like that before. And he just looked like nothing like
real tongue that I know.
Robin didn't even notice the rash. I don't understand how, because it was all over him. At the side of his bed was a pint glass, so I went and put it on his arm, and it didn't go down. And you never ever think that you're going to find someone with meningitis. I didn't feel a thing. I was just like, do this and do this and do this, and just make sure Tom's okay. So I was just like, ring an ambulance and just do that. Just take each step at a time.
Oh, ambulance. Hi, please can I have an ambulance in Belgian Court in South Gloucester, please? I think my friend might have got meningitis or something seriously wrong with him.
They brought me into the kitchen and sat me in front of the television to try and keep focused and watching a week of sleep, actually.
And he never watches it ever. And he was just staring at it.
It was a particularly good episode, I guess, but I was very into it.
I will receive a job to now type of switch on computer screen and typing a job for an early response, which is classified as a life-threatening emergency.
When the paramedic arrived, I just felt like relief.
He was very, very young. He was very, very poor. He was just very blank, staring at the television, not really responding.
Then when she came, she just asked me the symptoms, took a look at him, just like, right, I think it's meningitis.
They immediately, gave me antibiotics, I think, and there's no doubt that I think those drugs that they gave me there really saved my life.
And then we got to the hospital, and they took him straight in, to the patient's entrance, and I had to go, walk through and speak to the receptionist about his date of birth. And then I just sat in the waiting room, and then I got really upset, because I was, by myself in the hospital. Tom was really ill.
It wasn't really until I was in hospital, in A&E, and the doctors panicking and stuff, and telling me what was wrong with me. I was in this hospital bed feeling really, really ill, that I thought, yeah, I'm in quite big trouble there.
The doctor said that if we'd have found him an hour later, he would have died basically. And that's a really scary thought, that if I hadn't got a check on him, he could have been dead.
In the case of Kate and Tom, we saw how Kate helped Tom through his illness and was able to notify the ambulance very early on. The symptoms of meningococcal disease can include a high fever, headache, vomiting, neck stiffness, a fear of bright lights, and also cold hands and feet, and a rash. If you press a tumbler against the rash, it doesn't blanch, or the redness doesn't fade, and that is a very useful indication that this is meningococcal disease. If you or any of your friends recognize any of these symptoms, then seek medical attention immediately. There is a vaccine available for meningitis C. Now, meningitis C is one of several groups of meningococcal disease that can be prevented. People living in residential accommodation, such as students' halls of residence, are more susceptible to getting this disease.
I think the most important thing to come out of this whole thing is the importance of your friends checking up on you when you're ill.
People that I know that have heard the stories, so they're really more aware of the symptoms now, and not just to let people be if they're ill and to check if they're all right. It's kind of like united people in a sense. We were sat in a bar somewhere, and he was like, let me get you a drink, and I was like, no, it's fine, I'll get it myself. He was like, Kate, seriously, it's like, honestly, without you, I would not be here, and you did save my life, basically. So and that's when it really hit me, because to have it be said from him is totally different from someone else, and it was just like, all right then. I don't know, it really touched me, because I still don't regard myself as a lifesaver at all.
I do like to, be able to say how grateful I am, because I am, of course, very grateful. So my whole family, about what she did. So, yeah, sure. I mean, if we're out and about, I'll buy her a drink or two, because, she deserves it.
Okay. All right, are we back to the presentation? Back to the PowerPoint. And Kim said, great, now I'm terrified that I'll have a stroke or get meningitis and nobody will find me. I'm sorry, Kim. Make sure that people always know where you are, and if you're alone, then they check up on you. Brooke says, my friend got meningitis in college and it wasn't that scary, but she had most of the symptoms with weird bloody noses and stuff. The bloody noses can come from the increased intracranial pressure that can cause those sometimes. At the bottom of the slide, purpuric rash with meningococcal meningitis, definitely never touch that. Never touch anything that looks rashy or broken skin or anything. Always make sure that you put gloves on. All right, so for diagnosis and treatment, a spinal tap or lumbar puncture to look at the CSF. They'll look and see if there's increased white blood cells, and it will look purulent. So what I mean by that is when they do a spinal tap, it should be clear, like clear as water. Now, if it's slightly what they call straw colored, where it's just this light, barely yellow, like super dilute urine, but it's still clear, you can see right through it, then that's healthy CSF. If you start to have sediment or other, like a lot of white blood cells, it will look milky or kind of thick, and that's purulent. And you don't want to see CSF that looks like that. On the labs that they can do, CBC to look for a high white blood cell count. They'll look at the CSF and blood cultures. Always, always, always do blood cultures before you give antibiotics. So if your physician writes or your practitioner writes for antibiotics, then please always just double check and say, would you like me to grab blood cultures first? If you can't get a hold of them and you need to get this started, draw blood cultures. They won't fault you for that. That's actually very best practice. Antipyretics to bring down the fever so you don't end up with seizures on top of it from a high fever. Steroids will decrease swelling. Anticonvulsants, if they're having lots of seizures, then you would give that, but they don't give them prophylactically. And comfort measures, it's symptomatic treatment. So you have all of this different symptomology, and now we just need to treat the symptoms. So you put them in, let's see, my brother just does his own thing and knows someone. I sleep for like 25 hours. What? Oh my goodness, Kim. I don't think I could stay asleep that long. When I worked nights and days and flipped back and forth and stuff, I think maybe then I probably could have slept that long. So with your nursing cares and interventions, isolation. Put them on not just contact precautions, but droplet precautions. Make sure you're wearing a mask around them. Seizure precautions are wise because you don't know if they're going to end up having a seizure. A quiet, dark room. So very quiet. Come and go with the door. Just close it very, very quiet. Don't bang things around and be noisy in there. It adds to their headache so much. And then they're very photophobic. So that's like fear of lights, but it causes a lot of pain and a lot of headache. And so keep it as dark as you can. Close the blinds, keep the lights down, use your pen light to kind of get around in there and look at things. Medications that don't dull the sensorium. So here's where the verdict is out with some physicians. So you have a patient that has a terrible headache and a neck ache and overall just feeling really crummy. And so oftentimes they'll order Norco. Well, that has an opiate in it. If you are doing neurochecks for your patient because maybe they've had a decreased level of consciousness and you give narcotics, what might you find or not find? What's a risk with that? Oh, CX. Sorry, McKenna. Culture. Yes, thank you, Stephanie. Blood cultures. Decreased respiration, drowsiness. Yes, and yes. And so particularly the drowsiness. If you're doing consistent neurochecks, maybe every couple of hours, and you've given an opiate and your patient is worse, or they're just not any better, would you know that they are definitely getting worse or that they're just not getting better? Or would it be a question of, did the narcotics alter their level of consciousness? And so that's where best practice says not to give medications that dull the sensorium. So stick with your Tylenol, ibuprofen, Toradol. Toradol is like IV ibuprofen, and it's phenomenal. It helps so much. And then ice and heat. A lot of people ice to their forehead or around their head feels really good to kind of help constrict those blood vessels and decrease that pounding of blood in their head and decrease a pounding headache. And heat to their neck. You put nice warm towel along their neck, or you take gloves and fill them with water and tie them shut, and then heat them just a little bit in the microwave, or heat the water and then pour it in the glove, whichever. Kind of massage it around so you don't have hot spots, and then lay those warm gloves kind of behind their neck. And you can do the same with ice in the gloves on their forehead. Just make sure you put the iced gloves in a pillowcase. The pillowcase is thin enough that you can still feel the cool ice, but it's not thick like a washcloth where it'll keep it from getting very cold. And then cluster your cares. So get in, get done, and get out, and leave them alone for as long as you can. So if you have to do neuro checks every 2 hours or every 4 hours, then time your antibiotics, your vital signs, your eyes and O's, your neuro assessments, everything like that all together. Go in 15, 20, 25 minutes, get everything done, and get out. And stay out for several hours. It will help them rest, and it will help them overall feel better. And then educate them on your cares and educate them on vaccines. Menactra is one of the meningococcal vaccines. In the video, it says they have a vaccine against meningococcal type C, but they actually have another one, and I think it's B that it's against. So, and then one of them has a 2-step, so you get one and then you follow up with a second shot. I can't quite remember. So that's where you would also educate them on following up with the health department. The health department knows all those schedules. They know what's best as far as getting them all of the treatments that they need. All right, so before we go on to our next slide, let's take a quick break. Come back at 5 after 9, and we'll keep going on with prevention. Welcome back. Okay, let's keep going. So we have, let's see, I kept it recording so that I wouldn't forget to restart it. All right, so next one is prevention. Let's see here, let me go over to here. All right, prevention. So good hand washing, making sure that you're not carrying it from patient to patient. Talk to them about vaccines where applicable. So your meningococcal meningitis, your pneumococcal meningitis, and your Hib meningitis can all be prevented from those vaccines. So remember that you've got those 3 vaccines. And then isolation, put them on droplet precautions. Prophylactic antibiotics for those that are exposed. So not necessarily all the time, but if you have someone who's higher risk, then they might give them antibiotics. So like if you have a pregnant mom, sorry, I'm gonna sneeze. Okay, maybe not as soon as I said that. If they have a pregnant mom or if they have someone who has a lower white cell count for whatever reason, maybe they've had a splenectomy, maybe they're on chemotherapy, and they've been around this patient that's now been diagnosed with bacterial meningitis, then they'll give them prophylactic antibiotics. Okay, viral meningitis. It's most often caused by measles, mumps, enterovirus, mosquitoes, and herpes. Those are kind of some of your most common causes. Your diagnosis is also made by a lumbar puncture or spinal tap. With that, it can still be purulent because of the white blood cells, but it doesn't necessarily look as thick and kind of almost like a pussy-like appearance. It's not quite as bad when it's viral meningitis. It will resolve in 7 to 10 days. It's a virus, so it runs its course and it goes away. However, it takes such a hit to their immune system, it really sets them up for having bacterial meningitis. And you just do symptomatic treatment, exactly the same treatments that we did for bacterial meningitis. So your clinical manifestations are also the same as bacterial, except you have a decreased risk of seizures, decreased risk of permanent sequelae, and death. So a little bit better to fare that way. However, I have seen a number of patients that started out with viral meningitis and were so compromised that they ended up getting bacterial meningitis on top of it. The difference in your nursing care is no antibiotics. Otherwise, the care is the same as bacterial meningitis. Nice slide, huh? Not a lot of extras. You already got the information that you need for that. Prevention, same as bacterial. Good education, getting the vaccines, the MMR in particular. Isolation and good hand washing. Viral meningitis, pretty easy. Pretty much the same as bacterial meningitis, just not as virulent and no antibiotics. Encephalitis is more rare than meningitis, and it's inflammation of the actual brain tissue, not just the meninges. It can be caused by mosquitoes. They can get Rocky Mountain spotted fever. The ticks, they can get Lyme disease. And it's around here. My husband's boss last summer, so not this one that we're just ending, but last year, 2019, she got Lyme disease and she was just up in the US. Had a tick that bit her and she got Lyme disease. Herpes simplex type 1, mumps, HIV, cytomegalovirus, which is CMV, and distemper or parvo. Who usually, or what, usually has distemper or parvo? Where would that come from? Dogs? Yep. Cats. So animals that the child might be around, right? All right, so clinical manifestations can develop within hours. to weeks after the exposure. So they can get a tick bite and within hours they're very sick. Or they can get a mosquito bite and it's been a week or two and they're just really not feeling very good and they're getting worse and just not pulling out of it. Signs and symptoms, they'll have decreased level of consciousness, photophobia, headache, sound familiar, very similar to meningitis, high fever, but then you start to add a few other things that are more significant. Aphasia, so it's very difficult for them to speak or they don't speak at all. That can be expressive aphasia, where they can't express themselves and find the words, or it may also be receptive aphasia, where they don't understand what's being told to them. Hallucinations, that's pretty common with encephalitis, and seizures, much more common than even with meningitis. They can go into a coma and they can die, and those are higher risks with encephalitis for all of those. Getting a history is vital to the diagnosis, so don't limit your history to just a few questions. Be very inclusive and ask all kinds of things. Kind of be a sleuth and try and figure out where this came from. But you need to make sure that you ask about camping, about activities, about hunting, any sores from ticks or bites that they've had, and pets. Do they have any pets that they've been around? Make sure that that is part of your history, but not just the questions that you ask, that you're more inclusive than that. The nursing assessment, assess thoroughly for bites, sores, or lesions. And then ABCs and vital signs. You want to make sure you get a good baseline assessment, and you want to make sure that way you know if there are any changes in your patient from when you first came on shift. Make sure you get a good baseline. Nursing care, same as meningitis, so similar. Administer medications, all of these A's, antivirals, antibiotics, antipyretics, anticonvulsants. The anticonvulsants aren't given prophylactically. They're given if they are having seizures. And analgesics, they're in a lot of pain, very similar headache-wise to meningitis, but don't have the stiff neck as much. Antivirals, if it's very early on, like they got a tick bite and within hours they're sick, they can give them antivirals. If it's been like this long history over a week, 10 days, and they're getting worse and it's kind of slow, they won't give antivirals. They work differently than antibiotics. They help the virus, they help make it so that the virus can't shed. And so if it's already been long enough that the virus has shed and multiplied, antivirals aren't effective. And then steroids for swelling. So when I was in nursing school, I was on my ICU rotation, took care of this guy that was in a coma. He had had a sinus infection, and he went, and I lived in Idaho. I went to Boise State at the time, and we have like lots of little Instacares. They're usually more privately owned as opposed to here where they're kind of associated with a string of insurance-based Instacares, I guess. And so we called them doc in the box. So he had gone to a doc in the box, told them that he had these symptoms. They diagnosed him with a sinus infection and gave him erythromycin. Erythromycin makes your stomach really pretty sick most of the time. And so he took a couple doses and then didn't finish it. Well, it didn't go away, obviously. It got worse. And so he went to a different doc in the box, didn't tell them about the antibiotics, and they gave him erythromycin. And then he didn't take it. Well, he didn't show up for a family dinner. And so his brother went to check on him and found him in a coma on the floor. So they brought him to the hospital, got some burr holes kind of right here. I don't know if you can see right here in his sinuses, and stuck little Penrose drains in them and put gauze on his cheeks, or like right here in his, just below his orbital space. And it would just drain sinus drainage, thick, purulent sinus drainage right out of his sinuses. and he was in a coma. He was intubated and everything. And they weren't sure if he was going to make it, wasn't making some of the changes or milestones that they were hoping that he would. But in the meantime, his wife and his girlfriend came to visit. And so we were all really hoping that he would get better, not only because you hope that they get better, but then he'd have to face the music with his wife and his girlfriend. So you can't make these stories up. I promise you, you will end up with all kinds of good ones. All right, so with prevention, depends on the type of infection, depends on what has caused it. Isolation, so you want them on droplet precautions, good hand washing. Talk to them about vaccinations for their kids and for their pets. So the vaccinations with the mumps, so MMR, and then pets with the distemper and the parvo. So, yeah, Amy. Yeah. Yep. Ooh, wife and girlfriend. I know, sometimes. With the vaccination, distemper and parvo. So making sure that they have those vaccines for their animals that are around their little kids. And then back east and down south, actually down south more, and back east, they have some areas that are very, very infested with ticks. And so they do actually have a tick vaccine that they can give animals, but they only give them in really high risk areas. And then they can give it to the animals. They actually had a trial where they gave them to people, but they had some side effects, untoward side effects, and people just deemed it as too high risk. And so it never really took off. But it does do well for animals, particularly dogs. Mosquito and insect precautions, making sure that kids wear long sleeves and wear pants. There's DEET containing repellents. You have to be careful with those because some of the backwoods ones that are in the little tiny bottles can be 100% DEET. And those are for adults. You don't want to put 100% DEET on a little kid under about 10, but especially under 5. Little ones can have like 30% DEET. Their skin is thinner and they absorb more, so you don't want them absorbing a whole bunch of DEET. So if you put them in long pants and long sleeves, and then you spray around the cuff of their arm, spray around the cuff of their leg, spray it in your hand and rub it kind of on their neck, on their face. Don't spray it in their face. I've seen parents do that. And just make sure that they've got areas covered that aren't covered by clothing. And then get rid of any standing water. Sometimes people have little ponds or things like that at their house that really are kind of a mosquito infestation, and they need to really reevaluate kind of their landscape and see if that's necessary to have that, or if there's a way that they can make it more mosquito free. Let's see, the ones that have good DEET are good to clean foggy headlights with. Oh, well, there you go. I didn't know that. And then it makes sense that you wouldn't want to put it on a child's skin. Yeah, because they're very, they absorb it very much more than adults do. All right, so now we're going to talk cerebral palsy and then TBIs, and then we're going to play a Neuro Jeopardy game to be able to kind of review. So cerebral palsy is a malfunction of the motor centers and neural pathways in the brain. It is non-progressive. It does not get worse. What you have is what you have. It is also permanent. So it's a permanent disabling condition. So it doesn't get better. It's basically symptomatic treatment, and we treat it the best that we can with the resources we have, but it will never go away. So types of cerebral palsy with spastic, it's the most common type of cerebral palsy. The muscles of people with spastic cerebral palsy feel stiff. Their movements look stiff and jerky, and they have kind of a hyperactive stretch reflex where their legs are kind of they're kind of out and straight, and they're kind of turned in a little bit. And with their arms, I don't know if you can see me because my camera is kind of weird, but they're kind of pulled up like this in contractures, and they're very, very stiff and hard to move and hard to do range of motion with. Affetoid is where they have trouble controlling involuntary movements. And so they will have, like, they'll kind of do this with their arms and their hands and just kind of move them around, the involuntary movements. So when they're just at rest, they kind of do these little writhing movements. And then with hypotonic, it's low tone. And so with the low tone, they have very diminished capability to hold their head up. So they may not make that milestone very well as an infant. They don't have good trunk control, and so they don't sit up well. So you might have a child that really has a hard time eating. And so they need to be sat up, straight up in like a high chair or something, tuck a little blanket around them to keep them kind of sitting up straight. And then sometimes they'll need help with their jaw as they start to chew and start to learn how to manipulate food. And parents can kind of help with jaw strength. And physical therapy can work with this too, occupational therapy, and they really can help give resources, but they do need some help and some support because of those weak muscles. Ataxic is disorganized voluntary movement. Another thing I was going to say about hypotonic is they don't protect their airway very well when they're really little, and they don't hold their head up on their own. So it's something that needs to be, that's a concern, needs to be watched for kids that have hypotonic cerebral palsy. Sometimes, sometimes they will need a feeding tube that's a G tube so that because they're an aspiration risk. And then ataxic is the least common type of cerebral palsy, and it's characterized by muscle movements that appear, they're like disorganized and jerky, very clumsy. Some of these kids that are ataxic can walk, but they walk in kind of like a little scissor, and they kind of move their legs like this. I can't see if I can see that. It's definitely disorganized. If they go to grab for a cup or something, it usually needs to have a lid on it because it's very jerky movements to try and get it to their mouth. And then you can have mixed types. So sometimes they're very spastic in their upper extremities. Their little arms are just kind of locked up like this. And then their legs are very hypotonic and just very flaccid. There's several causes for cerebral palsy: prenatal, perinatal, and postnatal. So prenatal causes can be maternal infections, brain malformations, and multiple gestation. The more babies there are, the higher risk there is of one of them having cerebral palsy. Perinatal can be anoxic injuries, so they're in the birth canal too long, they have the cord around their neck, whatever the case may be, they end up with an anoxic brain injury, can cause cerebral palsy. Prematurity, every week counts. And so they really, best practice shows, unless mom's health is in danger or baby's health is in danger, then scheduling C-sections weeks before is not best practice. Every week that they are early, the risk goes up. They can end up with a stroke or an intracranial bleed as a preemie, and so that can cause cerebral palsy also. And then postnatal, under 2 years old. So if they have these problems like a head trauma or CNS infection like meningitis, and they're under 2 years old and they end up with a diagnosis of cerebral palsy, that's kind of where it's limited. If it's over 2 years old and they have a head trauma or CNS infection, they'll call it just a permanent sequela or like a permanent problem that came from having meningitis or that came from having a TBI. So once you reach 2 years old, they kind of separate that diagnosis. And then kernicterus can also cause cerebral palsy. Remind me, what's kernicterus? I'll remind everyone, I guess. Yep, bilirubin. Perfect. Good job. So clinical manifestations, many of them are prone to having seizures, to having a seizure disorder. Hearing and vision impairment, delayed gross motor. And sometimes it's so delayed that they never reach some gross motor milestones. They can have a poor sucking reflex, poor feeding, and a lot of drooling. So the kids that have the hypotonic, where they have very low tone, can drool a lot because they can't maintain their secretions very well. Primitive reflexes sometimes will stay around a little bit longer than they should, because some of these kids have other neurological issues and developmental delays. Cognitive and development problems, they will have intellectual disabilities often, not all the time, but very, very often. And so you might have a 12-year-old that operates at a 4-year-old's level. And so you treat them like a 4-year-old. It seems so strange in a bigger body that you talk to them like they're 4. You treat them like they're 4 because that's developmentally where they're at. And then they can have behavior disorders because sometimes they're just delayed enough to know that they're different. And then that, with that being the case, then they throw a lot of temper tantrums and they have other behavioral issues. So prevention, prevent prematurity the best that you can. Intervene to decrease birth trauma so that they don't have an anoxic injury, so that they're able to come through the birth canal a little bit easier. And this is where sometimes if the baby's getting too big, then that's where a physician might go ahead and say, we need to deliver this baby this week as opposed to waiting one more week. And so that they can make it through the birth canal without ending up with a C-section. Maternal vaccines, that's where a lot of the moms need to have an MMR or something before they leave the hospital. And then no scheduled C-sections before 40 weeks. Best practice says not to. A lot of physicians will choose to, and they have a variety of reasons. But the best practice says no. Let's see here. Nothing in the chat. Okay. Nursing interventions for cerebral palsy. So this is where, if you were in class, I'd be throwing ping pong balls at you. And each ping pong ball has a nursing intervention for CP, and I'd have you tell us what it was. So sorry, I can't throw ping pong balls at you. So your nursing interventions for CP to work with physical therapy. So when they work with physical therapy, they help them put on braces, and they might put them on their hands. So they might have their little hands kind of locked in like this, and they'll do some range of motion, and they'll get it kind of opened up, and they'll open up their fingers, and then they put this brace on that's been molded to their hand. Might have some Velcro straps around here, and then it comes down and it curves over their fingers. Might have a Velcro strap right here across their knuckles. And then you wear that, or they wear that, for about 2 hours. And so they'll write a schedule of on to, off to, or on in the day and off at night, but that's really long to have those braces on. So often it's on to, off to. And you need to make sure you're doing good skin assessments with those because they can get hot spots like on their wrist, on their knuckles, on their hand, or if you have them on the legs, you can have them on their ankles. Supportive braces. So some of these kids wear braces on their legs so that they're able to walk. Feeding and aspiration precautions, kind of with the low tone, the hypotonic kids, making sure they're sitting upright and that parents know how to help from being trained with occupational therapy, how to help them eat. A lot of these kids are aspiration risks, and so they will have a G-tube so that they don't have, that risk isn't as high. Repositioning and skin care is really important because a lot of them are immobile or not really mobile. So maybe just a little bit. And so watching for hot spots on shoulders and hips and when they've been on their side, any elbows, knees, that kind of thing. Communication, they're nonverbal. Sometimes, more common than not, they have some speech delay or speech impediment, or maybe they developmentally, speech-wise, they are much younger than they are physically. But sometimes they're nonverbal altogether. And so parents can tell by different kinds of noises or different kinds of cries if they're comfortable or if they're happy or if they're tired or irritable or if they're hungry. They can tell you by different ways that they act or that they grunt or moan or cry. Promote their independence. So let them do whatever they can do. If they are used to brushing their own teeth first before parents finish up and do a good job, then let them brush their teeth first. If they like to get up to the bathroom and they can walk with their little walker or their crutches or something, let them get up and don't make them have to use a bedpan or have to use a urinal. Keep their routines the best that you can. These are chronic kids. They are 24/7. This is their life. And so when they come into the hospital, be the least disruptive that you can be. And make sure that you try to schedule medications around nap times or bedtimes or that kind of thing. Medications like Botox and baclofen. So they will have, Botox is just botulism, and they will come and they'll inject it in the Achilles tendon to kind of relax that muscle and relax the spasticity in their legs. And with baclofen is an antispasmodic, and we'll talk more about it here in just a second, I think on the next slide. Surgery, they can do a selective dorsal rhizotomy, and that's where, Megan, yes and yes. So I will tell you on the next slide exactly the answer to that question. With a selective dorsal rhizotomy, they go in and at the base of the spine, they damage or cauterize or cut. Usually they cut a couple of nerves at the dorsal root that innervate the legs or that innervate the arms, and they cut those dorsal roots so that they relax those muscles. They're not getting as many impulses, and so it relaxes them. There is a risk with that they cut too many and they've gone from spastic to hypotonic, and now they went from being able to walk to now they can't. So they really are selective about which ones and how much they cut. But they are very effective when they do it and they do it right. And then educate family members. It's your job to educate along with PT and OT and speech, which is also ST. So you'll see PT, OT, ST. Sometimes in the orders, they'll write consults for all of those. And so really work well with your therapies and help educate your families. All right, so baclofen is an antispasmodic. They can be given PO or intrathecally with a pump. So the pump will often, it's just a little bit bigger. It's kind of round. I can't see, yeah. And a little bit bigger than a pacemaker or a VNS, a vagal nerve stimulator. And they usually put it in their belly, just below their rib cage. A lot of these kids are tiny and skinny. And so you'll see like this big bump, this big round pump in there. When they have PO doses, they can be very, very high doses. But as soon as they do it intrathecally with a pump, the doses are tiny. And the reason is with PO, it has to go through the liver and the kidneys and get all broken down and have that bioavailability with what amount actually works with the half-life of the drug and everything like that that goes along with the PO medication. Intrathecally, it goes right into the vascular system, and you don't have all of that, the liver and the kidneys and all the breakdown that's happening there. So if they've gone from PO to intrathecal and they've gotten a new pump, have to be super, super careful with their dosing because, like the next line says, there is no reversal agent. And so they really have to be really careful, and they will often err on the low side because you can always give more, but you can't take it away until it wears off and the half-life is over. So symptoms of an overdose, so it's very similar to an opiate overdose, very lethargic and weak. They'll have a decreased level of consciousness, poor respiratory effort, low SATs, sluggish pupils, poor hand grips, and be very confused. This is the case when they have too much, but when they are too low and they have symptoms of withdrawal, we used to call it itchy, bitchy, witchy, and twitchy. And so itchy, they get very, very itchy, and sometimes they can get a little bit of a rash. Bitchy and witchy, they get very ornery, irritable. They have kind of that high-pitched neural cry, and they just are really, really uncomfortable. And if they can complain, they'll complain a lot. And if they just are developmentally delayed enough that they don't complain, they'll cry. And then twitchy, you will find that they just get involuntary muscle twitches. And so those are signs that they're going through withdrawal. And you definitely want to make sure that you let your physician know either way. Signs of an overdose, we need to back off that dosing. Or signs of withdrawal, we need to up that dosing just a little bit. Did that answer your question, Megan? Perfect. All righty. So any questions on cerebral palsy? Crickets. Okay. I guess that's a good thing. Let's see. What's our time? Okay. So here's with the TBI. I'm not going to go into the whole big, like, in-depth thing that you had with adults, but we are going to talk about a couple of pediatric considerations. So with your GCS, you have a children's, modified children's coma scale. So I'll flip to the next one and we'll come back to this. So the modified children's coma scale, they have eye opening, which is the same. When you look at verbal, it's different because maybe they're nonverbal. Maybe it's because of age, maybe it's because of development. And so the very highest one is they coo or they babble, but it's something that seems to make sense to them. So they're just making noise. You know how sometimes babies just make all this noise and they look at you like, yes, do you understand what I'm saying? I'm saying all these great things. They can be very irritable. They can cry in pain or just moan in pain or do nothing. So those bottom three are very similar to the adult scale, but the top two are a little more tailored to a child. And then after the GCS, so initially at the scene of the accident or whatever has happened, then they'll do the GCS. They'll come in through the ED or come in through the clinic and they have a GCS score. Once they've decided that it is enough of a concussion or whatever that they need to be watched, they admit them to the hospital with like a 23-hour watch or something before they decide they're going to admit them or not. Then they will do this other test called a COAT test. And it's Children's Orientation and Amnesia Test. It tests general and temporal orientation and memory. So the general is like their name, their parents' name, their age. Temporal orientation is like the year, the month, the day of the week. And then with the memory, can they count forward or backward? Or if you show them a picture of a cartoon character, do they know their name? That kind of thing. Maybe if they remember your name, whatever. Some of those little simple memory questions. And they can repeat that about every 8 hours. And so the reason I put this COAT test in there is so that you're very, very aware of what the test is for. And I don't think, let me see here. Nope, I used to have the COAT test in here, but then people were trying to memorize it. And so it gives them scores in different areas. And then they tally that up. And 8 hours later, they see if it's getting a little bit better. if they're making any changes in any areas. And then they'll follow up 8 hours later. And then they can see that, yes, they came in with a GCS of maybe 13 instead of 15. But now with the coat test, we're showing that that bonk on the head, even though it's a concussion, they're getting better. They're seeing some improvement. All right, we've got that. All right, so teaching after concussions and TBIs, this will be similar to what Wendy gave you and what you and Vicki may have talked about also. So teaching after a concussion or a TBI, so you need to observe them for at least 12 hours. Now in your book on page 730, it says the caregiver should observe the child for at least 6 hours for vomiting or a change in level of consciousness. Best practice actually says 12 hours. I don't know if that's newer or if that's something that the book just had missed, but best practice currently says they should be watched for 12 hours. They don't say that that has to be in hospital. That could be at home. And so if they're asleep, that kind of on the next line, try and keep them awake. But obviously for 12 hours for a kid that's just smacked their head, they're going to want to rest. So if they're asleep, wake them up every 2 hours. Now, I always tell parents if they go to wake them up and the kid's like, "Wah, get out of my face," that's pretty appropriate. And then you can let them just sleep. If you try to wake them up and you can't, and that's gotten progressively worse, then they definitely need to go back in to be seen for increased intracranial pressure. Extreme lethargy would be something that they would watch for, especially over those 12 hours, but even into the next day. No sedatives. That's the same with the meningitis, where we don't want to dull the sensorium. So we don't want to give sedatives, even if they're having a lot of pain with their headache. Giving them Tylenol is kind of the best thing. Sometimes they'll give them a little bit of Norco. Sometimes they'll give them Tylenol 3, like Tylenol with codeine. Not as much anymore with the codeine as they used to, but always question the sedatives. Because if we give them a sedative and we send them home and we tell parents bring them back if they're too lethargic, and then they get home and they can't wake them up very good because we've given them a sedative, they're going to end up coming back and having another visit. No NSAIDs. Reason for no NSAIDs. Increases bleeding. Yep. And we've just had an injury, sometimes a shear injury, where you shear some of those blood vessels and shear some of that tissue. And so you don't want to thin their blood. You don't want to give them a risk for bleeding. Pupil or vision changes. So make sure that families know that if they have any pupil changes. Now also tell them that make sure that the light is the same. So if they're laying on the couch and you have a lamp on one side, that pupil is going to be a little bit smaller than the one that's further away. And I didn't realize this before I was a nurse. One of my kids had gotten a smack on the head, and they just told me to watch their pupils for being different sizes. And I went to went to open his eyes and see if he was awake and stuff. And one was smaller than the other. And I panicked and called back to the ER. And they said, "Well, what's the lighting like?" And I thought, oh, that's really good. That's really good to know. So make sure that parents know that the light needs to be the same or not to be too concerned about the pupil differences. Any changes in level of consciousness, especially if they're going backwards. So we've gone forward, we're making a little bit of progress, and now all of a sudden we're going backwards. Emesis, so sometimes they will throw up in those first few hours, but if they're continuing to vomit or they're getting that intractable vomiting where they just can't stop. And then doing education about helmets. I cannot tell you how many accidents I saw that I took care of that could have completely been prevented if they had been wearing helmets. And, I used to take a lot of pride in the fact that my kids had every kind of helmet. They had motorcycle helmets, they had skiing, snowboarding helmets, they had bike helmets, and Now that they're older and they're well into their 20s, I have longboarders that don't wear helmets. And I just think, oh my gosh, after all the years and all the training that I gave you as a trauma nurse, you still don't see it. So my poor 15-year-old that longboards with them and wears his helmet is like, oh, well, I guess I'm kind of the odd man out. But I worry that, you know, if they were hit by a car, that would be one of the only things that might save their life. And sometimes parents will say, oh, they're just those little tennis shoes that have the wheels in the back called Heelys. Oh my gosh, those are so dangerous because they usually glide through the grocery store and that's a slippery surface. They can come right out from underneath them and smack their head. I took care of a little girl one time that was on just a little razor scooter, about this far off the ground, you know, with the just the little foot plate and wheels on each end. She was just going along, hit a raised piece in the sidewalk where it went up just a little bit and it stopped her fast. And she went forward and pinned her hands under her body and fell and hit her head on the ground. She was in rehab for, I want to say like 2 months, but it's kind of escaping me now. 2 or 3 months. And when she left, she could walk, but she didn't talk. She could eat, but she wasn't continent. And so she was diapered. And that was where they thought that she would probably stay and wouldn't progress past that point. All right, so return to play after concussions. It's a concussion is just a type of traumatic brain injury. It's what they call, like they have a mild traumatic brain injury, moderate and severe, and it's more of a mild traumatic brain injury. The athlete needs to have completed physical and cognitive rest and not be experiencing concussion symptoms for a minimum of 24 hours before they return to play. Now, if it's more of a moderate head injury or they really had some issues at the beginning, then they definitely need to go longer than 24 hours. The younger the athlete, the more conservative the treatment is, and the athlete is at higher risk for another concussion or further problems. So it used to be the old, oh, my star player just got smacked in the head, came out, was seeing stars. Then they were like, how many fingers am I seeing? They said 2, great, we're back out on the field. And they would just put them back out there because they were the star player. If they get hit again or have any injury to their head while it's still healing, it can be catastrophic. It can actually go into respiratory failure because if you have a shear injury or axonal injury or contracoup where they hit one side and then it bounces back and hits the other side, any of those can set them up for with another injury causing inflammation that will herniate down the brainstem and cause respiratory depression, and they can die just from respiratory arrest. So with the return to play, you don't have to know the steps, but I want you to see, like right here where it says they have to complete physical and cognitive rest, kind of how that plays out. So step 1 is kind of back to regular activities. They come back to school. But before that, usually in the 12 hours that they're watching them, they say brain rest. And so that means no screen time. Not TV, not video games, not anything like that, not a phone. If they can avoid it, not any of those things. And they call that brain rest. Then they go back to regular activities at school. Light aerobic might be some jogging, moderate activity. So then now they can participate a little bit more in maybe the training or light strength training. Heavy is more weightlifting or heavy exercise, but it's still non-contact. And step 5 can be coming back to practice. If they're a football or lacrosse player, maybe it's full contact. And then 6 is back to competition. They can progress through these steps pretty quickly. There isn't a set time, but they really need to evaluate, and a lot of coaches anymore are being trained on these return to play steps. So just know that it's incremental, that they need to have focus on the first 12 hours and more this slide, the teaching and care after concussion. And then just know here that it's progressive, it's incremental, and it's based on their symptomology. All right, developmental considerations after a TBI. So this is where I would still be throwing ping pong balls at you because I want you to be able to have some other way to list this than just listen to me. All right, let's see here. Okay, nothing in the chat that I need to address. Developmental considerations after a TBI. So they can have delayed or stunted cognitive development, short-term memory difficulty, and if they have short-term memory difficulty, they don't hang on to it long enough to convert it to long-term. And so then they can end up with some long-term issues also. They can have delayed or stunted emotional development. So where they are when they get that injury, if they're 8 years old and they get a significant head injury, that's kind of where their emotional and cognitive development stops. And then as they move on physically, then the cognitive and emotional development will move on a little bit slower, but it'll be developmentally delayed at that age. And so you might have a kiddo who had a bad head injury at 8 years old, and now they're 12, but emotionally they still act like an 8-year-old. Maybe their cognitive abilities are more around an 8-year-old's. They can have erratic behavior, and it's often aggressive. And that can be when they're in the healing phases. Sometimes that's a permanent sequela that lasts, but sometimes it's just in those few days and months after the healing that they have this erratic behavior. They're more prone to suicide. So research is showing more and more these last two are more prone to suicide and more prone to drug and alcohol use. They don't feel right, basically. They don't feel like they have control over their memory or control of their emotions, or they know that they're not the same as everybody else, that they have issues. Sometimes if they already had some depression, then that can kind of push them over the edge to where they contemplate suicide. And then more prone to drug and alcohol use, mostly self-medication because they're having some depression symptoms or because they're having suicidal thoughts, or they're not. They're realizing that they're different from other people. There's something wrong with them, and that's difficult to accept. And so they might try to bury that in drug and alcohol use. And that is really not just teenagers or young kids, or that really can extend into adulthood. Those last three, the erratic behavior, prone to suicide, and prone to drug and alcohol use. Okay, so questions on what we've covered. All right, so I want you to stick around because I am going to take roll still for Neuro Jeopardy. So Neuro Jeopardy will be next. We're going to take a quick break, come back at 10 o'clock, and we'll play this game. We're going to split into 2 teams. And then when we come back in person, a little bit later in the semester, I'll have a prize for the winning team. So go ahead and just take a quick break, grab a water bottle, whatever you need, and then we'll get this started. Okay, so this is what we're going to do. We are going to split up into 2 teams. I looked through the chat when I took roll and looked through where you guys line up, and it lines you up by first name. So by first name, A through K is team 1. By first name, L through Z is team 2. So I'm going to put up the board, and then, yes, yeah, Daylin, yeah, join team 1. Perfect. And I'm going to put up the board, and then I'm going to ask anyone from team 1 to choose an area. If you don't choose within 10 seconds, if someone doesn't choose, then it will go to team 2 and vice versa. Then once you answer the question, if you alone answer the question, then your team gets 2 points. If you have to open it up, and you have 10 seconds to do that. If you have to open it up to the team, then you have 10 extra seconds with the team, but then you only get 1 point. So let's see, just place yourself in the list alphabetically by first name. We're all at the top of the list. Okay, so what you need to do is just go by, because on mine it shows up down the side alphabetically. So just know, first name, if your first name starts A through K, you're team 1. If your first name is L through Z, you're on team 2. Doesn't matter how it appears on the screen up here. Okay, so do the rules make sense? Everybody makes sense? Open your mics, type. Team 1 for the win. There you go, Aubrey. Okay. All righty. Here we go. So I'm going to put this up, and then team 1, anyone has 10 seconds to go. Oh my gosh. Sorry, 3 screens is a little difficult. All righty. I'm going to hide this so you can see down here. Anyone from team 1?
Can we do cranial nerves for 100?
Cranial nerves for 100. All right. Kylie Johnson. Here we go. Name the 12 cranial nerves.
Oh, do I have to do it?
So if you do it, you get 2 points for your team. If you have to open it up to your team, then you'll get 1 point.
Oh, okay. So it's olfactory, optic, oculomotor, trochlear, trigeminal, facial, abducens, accessory, glossopharyngeal, vagus. I always forget this one.
So,
and then hypoglossal.
Okay, so there's 2 A's, and you missed one of them. Tell me the 2 A's.
Abducens and accessory.
Oh, there's 3 A's, sorry. And you said accessory,
like,
and you said abducens. There's 1 more A.
Acoustic.
Yes. Beautiful. Way to go.
Thank you.
There they are. Okay. So team 1 has 2 points. All right, team 2. Time's a ticking.
Let's do CP 200.
All right, Miss Stephanie, CP for 200. Name 3 causes of cerebral palsy.
Do you want like prenatal, perinatal, postnatal, or do you want like in one of those sections?
Yeah, like in those sections.
Okay, so infection, prematurity, and head trauma.
Perfect. Let's get back over here. Yep, anoxic, brain injury and maternal infection, prematurity, head trauma, CVA, and infection. Okay, so team 2, 2 points. Actually, what might be easier is to go the full points or half the points. Does that make sense? So team 1 chose a 100 question and they got the 100. If they would have opened it up to the team, they would have only got 50. Does that make better sense? And then team 2 had the 200. They would have only gotten 100 if they opened it to the team. That makes better sense. You guys need to call me on things like this and say, what you're doing is not making sense, Chantel. Okay. All righty. Back to the board. Team 1, you're up.
I can do it, but I can't see the chart for some reason. It's not loading.
Oh, okay. So the categories are terrible TBI, seizure shakedown, cranial nerves, miserable meningitis, and
Cranial nerves for the biggest one.
Sorry,
Let's do
tell me again.
cranial nerves for 500.
Which one for 500?
Cranial nerves.
Cranial nerves. All right, going big. Cranial nerves for 500. A patient in a skiing accident sustained an injury in the lateral spinal thalamic tract. What symptoms are likely to be exhibited?
Pain and temperature. So
Shebang. Good job. Loss of feeling to pain or temperature. Good job. I didn't see who that was. Chelsea? All right. So that was team 1, correct?
correct.
Okay, for 500. Okay. So now we're going to go back to the board for team 2.
Do cranial nerves for 200.
Cranial nerves for 200. All right. Marin, let's see. Cranial nerves, 200. Your patient coming into the ED has fixed, dilated pupils, along with other traumatic brain injuries. What cranial nerve is damaged with fixed, dilated pupils?
Ocular motor.
Good job. Way to go. All right. And that one was, how many points was that one?
200.
200. Okay. All righty. Let's go back to the board. Team 1, you're up.
Let's do miserable meningitis for 100.
All righty.
Wait,
what is meningitis?
Team 1.
It's just like inflammation of like the meninges in the spinal cord and brain.
Yes, it is. And Kylie, you're right. Megan is team 2.
I thought it was team 1. Oh, I'm sorry.
Okay, so stay on team 1 now.
Okay. Okay.
Stay on team 1. Don't then go and answer for team 2.
Okay.
All righty. So yes, inflammation of the meninges of the brain and spinal cord. And that was 200, correct?
100.
It was 100. Okay.
Yeah.
All righty. We'll go back to the board here. All right, team 2 for real now. Four, 5, 6.
Olivia
7.
typed in the chat. She wants seizures for 200.
Seizures for 200?
Yeah.
Okay. That's Olivia that said that. Okay, so seizures for 200. Let's see here. 3 things you as the nurse should never be without when caring for a patient with seizures. They were bolded on that slide. Anybody? Now we're going to open it up to the team.
O2 suction and a bag or mask.
Perfect. 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 All right. Who was that? Leslie? Way to go. All righty. So we'll give you the 100 for that one, for opening it up to the team.
Olivia was trying to type it in.
Oh, was
she
she?
just needed a minute. She doesn't have a mic.
Oh, sorry, Olivia. I didn't see. Okay. So we'll go. Oh, there it is. Okay. All right, so we'll go ahead and go with the 200. It's a little tricky, I know, for some of you guys that are typing and don't have a mic. Okay, let's see here. All right, so we're back to team 1.
Aubrey wants nerves for 300.
Nerves for 300. All right, Miss Aubrey. I'll give you a couple extra seconds so that you can type. Which cranial nerve is the longest?
You said Vegas.
It is vagus. You're right. Think of that long strip in Vegas. And it goes clear from the medulla down to digestive and urinary organs. So it's a long one. And diabetics can damage this nerve when they have too high of a blood sugar. And so sometimes they will end up with digestive problems where their stomach doesn't, it's called gastroparesis. And it's kind of a paralysis in their stomach, and they don't digest food well, and they don't move it through, and they can end up with a lot of vomiting and stuff. So damage to that vagus nerve can have problems clear down, digestive, urinary, lots down there. Okay, so let's see here. I don't think I could have answered that one. Way to go, Aubrey. Good job. Stephanie, you have gastroparesis? That's a bummer. That is a really hard thing. It's managed well. Oh, good. Good, good. All righty. So that was team 1, correct? And that was 300. I'm trying to remember. That was Aubrey. Yep, team 1 for 300. Okay. Had to look back through the chat there. All right. You guys are doing good. Okay. Team 2. Maddie, TBI for 1,000. Okay, TBI for 100 for Maddie. What are the areas tested in the Glasgow Coma Scale? So like the 3 categories, what are those? You can see you typing. Eyes, verbal, and motor. Perfect, perfect. Okay. Eyes, verbal, and motor. So 100 for Maddie. All right, team 1.
What ones have we not done? Like,
I know they're a little hard with the blue. So TBI has all of them available except 100.
Okay.
Seizures have all of them available except 200. Cranial nerves have only 400. And miserable meningitis 2 through 5. And CP 3 through 5 and 100.
Okay. Kim wants cranial nerves for 400.
Cranial nerves for 400. Alrighty. Your patient's sense of equilibrium has been affected by an infection. What nerve has been affected? Okay, Aubrey. Almost. Think about your equilibrium. What can throw that off? All right, let's open it up to the team.
Is it acoustic?
It is acoustic. You are right. Or like auditory or vestibulocochlear, but yes, acoustic. So we'll give you half the credit for that one for 200. Yeah, when you get an infection in your middle ear, then it really can throw off your equilibrium. That's okay. Kim, that's fine. You did good. All right. Let's go here. All right, we're on team 2. Seizures for 100, Maddie Hill. All right. Can I call you Maddie or is it Madeline? Oh, Kimberly, acoustic. Yeah, sometimes the vestibulocochlear and is how I learned it when I went through nursing school. All righty, so Maddie is fine. We have a lot of Maddies, so Madeline might help separate. All right, Madeline Hill, seizures for 100. Here we go. Maybe if I can find it. Name the period directly following the tonic-clonic seizure. Postictal. Perfect, perfect. Postictal phase. So 100 for you guys. Good job. All right, team 1, you ready?
I'll do the CP miscellaneous for 100 if nobody else wants to.
All righty, Miss Brooke. CP for 100. Dun, dun, dun.
Kill me. I'm gonna go with an easy one.
Okay, I'm not sure how we'll do this one online. So everyone who has a mic needs to enable their mic. Oh, I changed it. Never mind. It was lead the class in the hokey pokey, but I knew we were going to do it online and you can't do that very well. So primitive reflexes need to be gone by when, or it's a big red flag. You want all those primitive reflexes gone by
14 months.
Yes, 12 to 14 months for sure, for sure. They prefer 12, but they don't get too concerned until it's about 13 or 14. Perfect. So that's a daily double. So it's 200 instead of 100. And that was team 1, right? That was Brooke? Okay. All righty, team 2. No 100s are left. 200s are only meningitis and TBI. 300s are TBI, seizure, and meningitis and CP. 400 is everything but cranial nerves, and 500 is everything but cranial nerves. So no cranial nerves left. Team 2.
Could we do meningitis for 2?
All righty, meningitis for 2. Miss Megan. What 2 tests should be performed before starting treatment for meningitis?
Cultures is one. Antibiotics. And then a spinal tap?
Yes.
Awesome.
Yes. Let's see here. I'm trying to run too many things. Okay, blood cultures and a lumbar puncture or spinal tap. Yep. All righty. So that was 200 for team 2. And we're back to team 1.
Can we do terrible TBI for 200?
You betcha, Miss Amy. All right, terrible TBI for 200. What is a concussion and why is it important for return to play rules?
So it's like a concussion is a TBI, like a more mild one. And why is it important to return to play rules? To make sure that like it doesn't get worse.
Yep. You are exactly right. Higher risk of getting another concussion or having further problems. So good job. So 200 for team 1. All right, here we go, team 2. Team 2, you're running out of time.
I can go again. I'll do
Okay.
CP
Stephanie?
for 300.
Which one for 300?
CP.
All righty, CP for 300. 3 interventions for cerebral palsy.
PT with supportive braces, communication aids or nonverbal communication, and medications.
Beautiful. Lots and lots. Love it. Way to go. 300 points for team 2. All righty. Team 1. Kim. Thanks, Marty. All right, some of you guys that haven't piped up. Team 1. 6, 7, 8. All right.
Aslan says TBI for 300.
Some of you same ones are carrying your teams. Come on, the rest of you guys step up. Okay. So that was Chelsea that lit up, or was that, oh, let's see. I have more messages further down. Let's see here.
I was just talking for Aslan.
Okay, Aslan. Terrible TBI for 300. Okay, I will watch the chat for this. The 3 areas the coat test covers and when it's used. It's like the 3 general areas. All right, team. General and temporal orientation and memory, yes. And when would we use it? Do we use it right off the bat or every 8 hours? Perfect. Yep. So after the GCS, right? The GCS is immediate. So we reassess for ongoing healing about every 8 hours. Good job. So that one you'll get 154 because we opened it up to the team. Okay, let's see here. All right, so we're on team 2.
Can we do CP for 500?
CP for 500. All righty. 3 signs of a baclofen overdose. So too much.
Lethargy, decreased LOC, and low stats.
Very, very, very good. Good job. Sleepy, 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 right? And it's irreversible, so we want to be very, very careful with that. Good job. All right, 500 for team 2. All right, team 1. Let's see here. 6, 7, 8, 9.
Can we do terrible TBI for 500?
Terrible TBI for 500. All right. Is that Miss Chelsea or Kylie? Which one?
It was me.
Kylie?
Yes.
Okay. All righty. Tell me again. Sorry. 500 for
TBI.
TBI. Okay. 3 pediatric developmental concerns after a TBI.
Like their personality could change. Like, will they be able to take care of themselves, do their ADLs, and their like cognitive development?
Cognitive development is what? What happens to it?
It could decrease, so it's harder for them to learn things or to read or do
Perfect.
stuff like
Good
that.
job. Yep, erratic behaviors, they can have some changes in their behavior, delayed emotional development, behavior problems. Yep. And more prone to drugs and alcohol. And then on here, I also forgot to put more prone to suicide. Good job. All righty, team 2.
Go again. Can we do seizures for 300?
Seizures for 300. Okay. So in addition to food restrictions, name 3 things a nurse caring for a child on a ketogenic diet must consider.
Well, they have to be, they can't eat anything for the first 24 hours. They have to like get into ketosis for it to work. And then they can't have like any flavored chapsticks or gum or like sugar with them.
Perfect. The flavored chapsticks, gum, and there's one more thing that's kind of a PO restriction. It was those 3 things.
They can't have like oral suspensions of medicine. Like cough
Perfect. Perfect. Yep, those 3 kind of off things you wouldn't always think of with a diet that's low in carbs. So good job. 300 for team 2. All right, team 1. Somebody speak up that's not been participating.
I can do seizures for 400.
Okay.
Jess, by the way.
I just see a phone number. Who's this?
Jessica Curtis.
Oh, okay. All righty. So you said which one?
Seizures for 400.
All right. Seizures for 400. Name 3 things you would say to educate the family of a child with seizures.
One of the big ones is not letting them take baths. Another one is making sure that they do activities that are dangerous with supervision, like swimming. And another one, like putting on a medical band. Would you count that as something to educate the family about?
Yep. Those are great. There's a whole list when to call EMS and NPO tell alert and all 3 of those things that you said. There were very, very good things in Maya's presentation about what to teach the family. So good. All righty. So that was 400 for team 1. All right, team 2.
Megan wanted one. Megan
Well,
Short.
I'll just
Megan
take
Short.
whatever's left. I can't really tell.
Okay, so you can have either meningitis for 3, 4, or 5. You can have TBI for 4, seizures for 5, or CP for 4.
Let's do TBI for 4.
TBI for 4. All righty. So name 3 things to teach a family member of a patient who has received a mild TBI or concussion.
Just to watch for like change of like LOC, like brain rest for the first 24 hours, and then just following like return to play protocol.
Yes.
Qualify.
Yep. Those are good. They weren't all ones that I had on here. I kind of had run out of room, but they are all very, very good. The return to play thing, especially if it was a sports injury initially, is something they need to be aware of to follow. Good job. All righty. We're coming down the home stretch. Team 1.
I'll do seizure shakedowns for 500.
Seizure shakedown for 500. And this is Shelby. Okay, wait. Shelby's team 2.
I thought I was team 1, sorry.
That's okay. So we'll do team 1 and then you can do team 2 right after. So hang on, Shelby.
Okay, sounds good.
I think Ashley wanted that one in the chat.
Ashley. Okay, so I see seizures and there's only one left. So seizures for 500. Okay. 3 times you should call EMS when a child has a seizure. Diabetic injury, apnea, beautiful. Beautiful, beautiful. Yep. Lots of different reasons here, but all of those are exactly correct. Okay, so we'll go back here, Miss Shelby. There is 500 for meningitis, or 345 for meningitis, or 400 for CP.
I'll take 400 for CP.
400 for CP. Okay. Name 3 things that are unique to an infant neuro assessment. This was right at the beginning when we talked about baseline for everybody, but these 3 things are unique to them.
Would it be like their level of consciousness? Sorry, I don't quite remember. Would
That's
it be
okay. We can, if you don't remember.
Would it do? No, I remember. It's fontanelles, the reflexes, and what's the last one? I remember it starts with the O.
Yep, it is an O. It's the OFC,
That's what it
occipital
is.
frontal
Frontal
circumference.
circumference. That's what it is.
Yeah, good job. I remember it starts with an O. Yes,
Yeah,
it does. Okay. All right, so that was 400 for team 2. All righty, so I think we have 3 left. So team 1 and team 2, you each get 1 more turn, and then that kind of leaves us with 1 left unturned. Let's see, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11.
I'll take meningitis for 500. How's gonna go?
Okay, so who was this, Chelsea? You'll take what?
Meningitis for 500.
Meningitis for 500. 4 nursing interventions for a patient with meningitis.
To turn off the lights, to make your checks cluster together to give him more rest time, and to just be quiet, be soft spoken because they have a headache and stuff.
Okay, that's 2. Give me 2 more.
Well, and dimming the lights.
Okay, yeah, you said lights and quiet.
So dimming lights, being quiet, and clustering the cares together, and another one for meningitis. Well,
nursing cares would be administering the medications.
Yes, perfect. Good job. Medications, in particular, your antibiotics, if you if it's bacterial. But you also have antipyretics to keep the fever down, analgesics because they hurt. So yeah, lots of medications. You are right. Good job with the 500 there. Okay, so then that leaves us with team 2, and you have 2 to choose from. Miserable meningitis, 3 or 4.
We'll do 400.
400. All right, Taylor, bring it home. 3 clinical manifestations of meningitis.
Like a high fever, stiff neck, and altered level of consciousness.
Bingo. Way to go, girl. Okay, so let's see here. Lots of them there, but you got some of the big ones there. So good job. All right, let me add it up because it leaves 1. I don't know. Maybe I should make this a little bit longer or something so that there's more columns. But let's see here. 6, 7, 8, 9, 10. Okay, 3150. So team 1 has 3150, and team 2, 4. 34. Ding, ding, ding. Team 2, you are my winners. So when we come back in class, in person, I want every team 2 member, that's L through Z, first names, to remind me that I owe you some good treats. Like, I love popcorn, so usually it's a couple of different kinds of popcorn. Okay? Battle it out for 3. Oh, okay. So is that like first one to weigh in, Kim? Or you get 2 people to go head to head? Okay. So I need a mic open for team A and a mic open for team B. Or 2, sorry. Team A and B, 1 and 2. Okay, Stephanie's going to be team 2. Who's team 1?
I'll do it.
All right, Kylie, you guys ready? Here goes 300. Oh, you both disappeared.
No, we're still here.
Oh, okay. It only lights up, I guess, when you're talking. Okay, here we go. 3 available vaccines aimed at preventing meningitis.
Oh my heck.
I know, I'm like, oh, shit.
The one red slide I didn't write down.
Meningococcal.
Okay.
Is it the pneumococcal or the HBV?
Oh, pneumonia.
Uh-huh.
Meningococcal, pneumonia, HIV.
Yeah, the Hib.
Hib.
Ding, ding. Way to go. Is that Kylie?
Well, Stephanie answered one of them.
I actually said pneumo and the HBV, but that's fine.
Shoot, I didn't hear the pneumo. I'm sorry.
Oh,
You're
gotcha.
good.
So
But I said
it was
HBV, not
so
HIV.
it was a collective effort. You guys did good. Good job. All right. So I will bring some popcorn for the class during one of the lectures. I think you guys are amazing. Good job. Okay. So hopefully that helped a little bit.
Or for one team?
What's that?
For the class or for one team?
I'll just, because these guys collectively went head to head with the 300, I'll probably just bring some good popcorn for you guys to all pass around and share.
So nobody won?
Well, team 2 can have bragging rights.
Okay.
Yes. So if you were on team 2, make sure that you brag about it.
I get bragging rights, but it's okay.
And maybe we'll give you guys first pick of the popcorn. All right. So last semester, since we were online and it's difficult to like come to my office and just pop by and ask a question or something like that, I tried to do some reviews of just kind of walking through the objectives real quick once a week. Most of the time that happened on a Friday morning at 9 a.m. So this Friday at 9 a.m., I'm just going to do a quick review. I will record it. I'll just walk through the objectives and give you a couple little reminders. And then next Friday, we're actually in PED simulation. So next Friday's topics for me is just sensory, and sensory is 1 hour. And it's not it's not real hard information for PEDS. And so I won't necessarily try to find time to do a review for that one. But then beyond there, most of the time, Friday mornings, I will be able to do that for you. So just remember, put that on your calendar this Friday at 9 a.m. I'll jump on for a quick conference. It'll say PEDS Neuro Review. And then we'll just spend about 20 minutes and go through the objectives, okay? But in the meantime, if you guys have burning questions, email me, text me, whatever you need. So you did amazing. If there aren't any questions now, then you guys can, I guess, hop off. And I will tell you have a good day. Peace out.